I'm a clinician, and my virology colleagues, really experienced and like phenomenally kind of, they dedicate their life to viruses and stuff, and including these kind of emerging viruses and stuff. And they're always kind of citing the different strains and the mortality rates. And it drives me crazy because in the field, what you'll get in some places, you'll get 100% mortality in some hospitals, in some regions, and at some stage in time. And when you talk to people that have worked in those high mortality, and I know, and it's the same with other viruses like Lassa, like when Lassa used to arrive in Freetown, no one goes near the patients. Like I think in Uganda, I think there was a hospital way out beyond Gulu, and people said, yeah, that the hospital that treated that, they called it the Ebola corner. They put the patients there. No one went near them. They died. And so in the context, if you don't have someone supporting you, you haven't. If you've got proper disease, severe disease, you're going to die. And so behind every survivor is someone who's helped them. And that might be the cleaner that helped them with oral fluids, or usually a female relative, an aunt or whatever, who's helped them hydrate and give supportive care. So I find that I find it kind of irritating to me. I understand where they're coming from because that's what you normally do. But in these countries, the standard of care is it varies so much, and it's compounded by the fear factor. So if people are frightened and they haven't seen a role model for care, they won't go near them. And I was like that. I remember, in Sierra Leone, I told my wife, when she was responsible for supporting the Lassa fever unit initially, and I said, don't go inside, just grab the data, find out what they want, you get the statistics, get the PPE requirements, and leave. Don't go inside.
Yeah,
And it takes a leap of faith, and I never forget. You're working with someone from CDC, a guy called Dan Bausch, and seeing him working. I went in with him to the Lassa ward, and I've never forgotten that change. You see someone that is sensible. They're not risking their life. They're not a maniac, and they're just following the precautions, and it works. And to have that faith usually needs some leadership. But DRC's got a lot of experience, but it is all over the place, isn't it? I mean, it's quite scattered. So I think that there may be variations in the case fatality rate across viruses overall, but it's usually going to be dwarfed by the degree of care and the timing with which people give that supportive care. So if someone arrives like 7 days down the line, the die is cast. All the data shows that pretty much by 5 days, and for some markers by 3 days, you can start to see who's going to die because of the degree of renal failure, for example, kidney injury. That's just one example. So so that, glad to get that out of the way.
It's something I saw at first hand as well. That's the real cruelty of Ebola and kind of viral hemorrhagic fevers in general, but talking specifically about Ebola here, is that it's a disease that kind of preys on human fallibility and preys on that kind of innate desire that's something that's so hard to resist, of helping kind of loved ones and relatives and so on. I mean, if you could, just talk to me a bit about that.
Yeah. So, I mean, it's not uniform in that there are other people who get the disease because they don't follow the advice, and but by and large, the hardest working nurses, cleaners, and doctors are, they're the ones that who definitely have a high risk, and especially in the initial stages when they're not supported. So they're rising to the challenge. They've usually recognized that what this is, but they don't have the level of support and equipment. And yeah, I think it takes out the best people in healthcare in these environments. And every country has its different stories. I'm sure I would have shared with you the story of Matthew Lukwia in Gulu in northern Uganda, who was the medical superintendent of the biggest mission hospital if not in the country, I think it was. It was described as the jewel in the crown of Africa, the mission hospital in Lachor in Gulu. And Matthew he was a medical superintendent, and he recognized that there were several nurses dying. And he was actually a fellow of the kind of Liverpool Tropical Medicine School. And he traveled back, and they worked through the night to implement hemorrhagic fever precautions. And towards the end of the outbreak, and he was such an experienced clinician, and I worked with him a lot. And we'd even discussed what would we do as we were getting on top of the outbreak and we had more resources. What if for now another member of staff gets sick? Would we have a go at intensive care? And paradoxically, it was him that then fell sick, and in spite of intubating and ventilating him, in a makeshift intensive care that I helped create, he died. He died of kidney failure, renal
What
failure.
year was that when he died?
So that would have been 2000, probably about November or December. I think 2000. Yeah.
Seeing this outbreak and reading about this outbreak happening kind of on the other side of the world and all the implications for that. What was that like for you, seeing another Ebola outbreak coming?
It's like what I said about COVID. It's like watching a train crash in slow motion, actually. I know I shouldn't, but I try not to. I try not to think about it, actually. And from what I see, I'm worried that a lot of the lessons aren't learned, and some of them are really difficult, the challenges. And that piece I wrote for a Lancet kind of blog thing about what went wrong in that last outbreak. Basically, it sounds like they've got unrecognized chains of transmission, and that they're having trouble with the follow-up of contacts. And if there's inevitably, even with really good contact tracing, you're going to maybe miss a few. But if you miss kind of 30, 40, 50%, then the contact tracing isn't working. So someone's now going to fall ill that you haven't been following up, monitoring every day. They're off the radar. They will seek care, particularly in that mining region, because there is, I've worked in a lot in Eastern Sierra Leone mining, in DRC with Marburg. Marburg's an almost identical virus to Ebola. Clinically, and it's even indistinguishable under an electron microscope. And I think that the differences are largely due to the kind of treatments in different countries. But that disease, Marburg, where I was working in Congo, DRC rather, Province Oriental, was absolutely linked to one particular gold mine, and the mining communities consist of fit young men looking for employment, above average wage earning. And then what then descends upon the mining community is exceptional number of pharmacies, prostitutes, and the health facilities. If like any young men anywhere that have got some money, there's quite a good income, and these countries are totally dependent in healthcare for private sources of income, so private facilities. So it's all fee for service, even if either over or under the table. So they will seek medical care. They can purchase it. They can travel, and in the context of poor infection control, because you can offer high quality medical care now in these countries, but you can't claw back the expenses to cover infection control. So you end up doing quite advanced procedures, hands-on, with as a way of, everyone has to do that to earn their income, because government salaries just aren't going to be working sufficiently. So the scene is set for amplification in healthcare. On the burial side, it's my experience that eventually, after many cycles of funeral, families and friends and people dying after a funeral, the message gets across. I
Okay.
think communities learn. It takes a while, tragically, but
Yeah.
they learn. But with healthcare, if they travel, because if some clinics might shut down in the hot area, but with travel opportunity, it's completely different country.
Mm.
DRC, all the travel links.
How
So I
many
think those are the ingredients that frighten me.
how many times have you been to DRC, and have you visited the specific province where this virus originated from as well? Or this outbreak,
Not this
sorry.
specific province. I was in Province Oriental. Um,
Which part of the country is that in?
that's eastern Sierra
Okay.
Leone.
Eastern DRC.
Eastern DRC, sorry, DRC. Um, and I would it would have been a couple of days motorbike ride from the border. I was dropped off by plane, but I was kind of my contingency to exit plan if a plane couldn't come in and pick me up was, I think, a 2 day. It's pretty remote. So I was there for 4 months. I was the only WHO person there. I was on my own, to look for and treat and teach the local staff how to treat Marburg, hemorrhagic fever. Those jobs, it was a weird job at the time. You can imagine, like, no one would be allowed to do that nowadays. I mean, I'm surprised they hatched a plan like that. So for 4 months, I really got to know. I didn't go into the mine. I thought about it. I interviewed miners extensively about the conditions, and I got samples. I got sufficient samples to help with a paper that identified the different strains of Marburg, past and present strains that were still co-circulating from that one mine.
Okay.
So in other
What
words, the mine was acting like a deep freeze.
what year was that you were in that part of
That
DRC?
would have been that would have been 2000.
Okay.
Early, yeah. It was before. So it was. I was on my way home when the news from Gulu happened. I was in WHO. I was supposed to go home, and it looked. They said it looked like either Marburg or Ebola, and would I
Okay.
go straight back out? So I went to Uganda. So altogether, I did about 6 or 7 months nonstop with the hemorrhagic fevers that
Do you
time.
think this particular outbreak, do you think that is related to mining as well? As far as I can see, it
My
hasn't been.
my personal feeling is that there is something about the mining, um, that um, there is this link, and and the ingredients of mining. I'm not so worried maybe about the open cast mining, but shafts, um, where you've got an environment that's a niche environment. You might have, like, that Gurumba mine, that one mine in Province Oriental, in Durba Watsa province. There'd be over 1,000 men a day down there. They'd have to pay to go down there. It's an illegal ticketing system, and they're not going to come out to use the lavatory. They're going to, and they stay days down there, and they would only stop when there'd been a bad rockfall and it smelt so much from the putrefying corpses. And then they would swim through underground sumps to get to other terraces underground. You could tell an unconscious miner by the scars on their legs, because the fresh cut rock is very sharp. So they drink the water off the side of the walls. There's bats in there, thousands down there, and bat everywhere. And you've got no ultraviolet light. And these viruses are very fragile to weak oxidizing agents. We're incredibly lucky in that. And again, I think it's such a shame that we're not capitalizing on that. And there'd be much more confidence if we got, for example, Port and Down to share the data that they must have on, because everyone, it's a first thing you look at, for biological weapons research and safeguarding, is the susceptibility to weak bleach solutions. So that data isn't available. I believe it's still not available. But it's just a phrase like, oh, they're weak, they're susceptible to weak solutions, and so we use a 1 in 100 bleach. You can use that on your intact skin; it won't harm you, and that will be enough. So I think the mine is a very unique niche environment, and I think it's linked to that.
I mean, it's up there with 2014 at the minute in terms of the way the numbers are spiraling.
The rate of increase. I mean, from what I see, I mean, I think CDC numbers are a little less than WHO, but from if you've got that data on the speed of increase in cases, and in particular the different geographical places that, for example, one epidemiological team will not be able to cover, several of the areas, so you're going to have, you're now breaking up your response. The quality of those epidemiological teams for contact tracing is crucial. So I think that they're lagging behind. That's the worry. If that is the case, even though DRC's got a lot of experience of Ebola and Marburg, and then I think we're in trouble. We're in trouble.